Welcome to Basic Black. Some of you are joining us on our live broadcast, and others of you are joining us on Facebook Live and Twitter. I'm Callie Crossley, host of Under the Radar 89.7. Our topic tonight, the challenges facing doctors of color. Even as the country grows more diverse, there are still gaps in many professional ranks, especially in medicine. The facts are, most patients have never seen a doctor of color, let alone be treated by one. How is it that there continues to be a dearth of medical doctors in the 21st century? And how does the lack of diversity play a part in the health and well-being of communities of color? Joining me tonight, Dr. Ariana Vora, an integrative rehabilitation physician and an assistant professor at Harvard Medical School. Dr. Imo Isiku, an emergency medicine physician at Brigham and Women's Hospital and an assistant professor at Harvard Medical School. Retired heart surgeon Dr. Arun Singh. Dr. Singh is also a clinical professor emeritus of surgery at Brown University and an adjunct professor at Bryant University. And Dr. Numa Perez, general surgery resident at Massachusetts General Hospital. He's also an innovation fellow at the Mass General Healthcare Transformation Lab. Welcome to all of you.
Thank you.
Welcome to having us.
I just want to bring attention because we say there are low numbers and people think, well, what does that really mean? Well, here's what it means. With a study that just came out earlier this year, just a couple of months, they just listed the numbers of students in medical school, and they broke it down by ethnicity and race and gender. And so there are 91,391 medical school students at this point. 40,000 of them are white. Mm-hmm. Everybody else is in the rest. And the numbers get so small as we keep going down, like with Native Americans, for example, that's 214. Yeah. Some of the highest numbers right at this point are Asian at about 20,000, but they are tiny, tiny. And we've come a long way, as Dr. Singh would say. But Dr. Singh, when you arrived at Brown, you were the only Asian physician there.
That's right. When I walked in 1972 at the Brown, I was the only Indian walking through the corridor. Everybody looked at me a little bit different. They would ask me the question, where are you from? Are you Caribbean? Are you Latino? Are you from somewhere else? And people, even they were educated, the way they reacted was very funny. The question that when I tell them that I'm Indian, they will ask, oh, you all eat vegetarian, aren't you? Eat any meats? My answer used to be saying, look at the elephants. They're pretty big.
Okay, Dr. Singh.
Look at the horses. They don't eat. They run pretty fast. So they'll never look at it. And then when I ask the question, they said, oh, you must be living close to Taj Mahal or elephants. Then they asked me, do you wear a diaper? Because the only picture they saw, they remember Gandhi.
Yes. All right, so I just want to rest it right there because my point was that you were the only one there.
That's right.
That's right. And that was 1967. I'm going over to you, Dr. Isiku, because 4 out of 800, there were 4 students of color out of 800 in your class.
Correct. It's at the time there was actually 400 total in the school, and there were 4 in my class and 2 in one other class, and so my class of 4 was considered a large class for us. And one of the interesting things was I had an opportunity from a medical perspective to lead the Student National Medical Association, so we actually got to look at what the numbers were, and I was just thinking when the study came out that we were roughly at the same numbers then 20 years ago as we're here now, so a lot of work still to do. But still, I think we can do great things.
Numa, when you came to do your residency, not very many. In fact, you had to do the same kind of work that Dr. Isiku did and start to recruit other Latino doctors because there are not many. And by the way, and just so folks know, the numbers of Latino doctors has dropped since 2010. So at one point there was 135 in school, and now there's 105.
Mm-hmm. Yeah, I mean it's certainly been I don't want to say a lonely road because it's not lonely, but it is certainly when you look around, there aren't too many people that look like you, and it's been the same, from medical school even now, and this is not a reflection of the people around me, right? My colleagues, my the leadership, my mentors at MGH, they're all great. But the reality is the reality. I look around and there's not that many Latino residents. And as you say, the numbers have either stayed steady or dropped. And the numbers are pretty stable across the nation as well. So
here we are.
We have a generalized problem. Yeah.
Dr. Vora, when you started off, everybody was asking you the same kind of questions they were asking Dr. Singh.
That
what are
is
you?
correct.
I don't understand. Do you speak Spanish? You must fit in one of these categories.
That's right.
And there weren't very many other people that looked like you.
That is very true. Yeah, since childhood on, what are you has been a daily question for me growing up in Minnesota, small town Minnesota. And all the way through, I've been identified as many different ethnicities. It's the experience of feeling that you're the other, the them to the us, and that's definitely still there. Yeah.
So I want to put the numbers on the table because we always want to ask so people know, what we're talking about. And then we can talk about why it matters that there are so few and why we continue to talk about it. So let's start off with you, Dr. Newman. Why does it matter that the numbers are small?
That's a very good question. I mean, diversity for the sake of diversity, just so that the picture looks pretty, it makes no sense, right? It matters because we live in a country where over 17% of people are Hispanic. You've got 12% of people that are black. We ideally want our provider population to reflect that diversity, right? So that when those patients come to our hospital, they look around and they see that the provider population reflects them, so that we're able to better connect, to better provide care, so that things like implicit bias, which is basically just something that comes along with your 20, 30, 40, 50 years of experiences, so that those sort of unconscious attitudes that you've built throughout your entire life start to chip away as you as a provider start to surround yourself with providers that look different than you, that have different cultures and such. And so you begin to shed those implicit notions that perhaps don't even match your explicit statements, your explicit ideas, and so that's why having a diverse healthcare sort of provider population matters for patient care.
Same with you?
I think that's a great question. And what I sort of thought about is how there's certain areas or industries where you need a basic trust for the relationship to work. And medicine is one of them. So every time we engage in our patients, they're really in this position where they have to feel like they trust you in order to take the medications or prescriptions or regimens that you ask for. And so when I think of why those numbers matter, it really matters because in the environment we're in, we're naturally, whether we like it or not, we naturally have a certain amount of more comfort or trustability when the person looks like us from across the room. And the less that occurs, the less opportunity for an intrinsic trust to develop. So when I think of those numbers, it's important because the more of those physicians or providers we have and our community continues to grow in that way, the opportunity to connect, change their trajectory from a healthcare perspective, their compliance with meds really, really matters. And therefore, it's kind of incumbent of us as healthcare providers to try and have our workforce look like a community, because it ultimately makes a difference how they trust us when they need us to help them.
Dr. Vora, why does it matter?
Well, I agree with what's already been said, and the research shows it, that there are good studies on this, that if the Stanford study is one that people know pretty well, that if you match African American men with an African American male doctor and a Caucasian male doctor, in this study, the patients were much more likely to ask for preventive health care services when they were talking to the African American doctor. So it's about trust, and I think it's about relatability. It's very important that physicians connect with the community that we serve, and it makes a big difference if you've got a shared background and you have a relatable way of relating. But I think there are even opportunities, of course, for all doctors to need to connect with the community that they're serving. But there's no question that healthcare outcomes are going to be better, disparities will be less if we have a more diverse workforce in medicine that looks like the people we're actually treating. It makes a difference, and the research shows it. And it's got to do with history. It's got to do with, you know, the historical problems of hegemonic society that we're aware of. And that trust has got to be really earned by everybody, but especially in populations that we know have been really marginalized throughout our history, unfortunately.
Why does it matter, Dr. Singh?
Well, I think as everybody cover almost same thing. You know, I think patients will relate better. They feel comfortable. They see their own. They can talk to them. They understand the problem. If you see somebody stranger who does not understand kind of higher ethnic, you know, bigger financial situation, he doesn't understand what it's like living in a ghetto, what it's like a sharing on a welfare or whatever it is. So it's very, very important that that the physician, the provider, represent the service. And as you know, pretty soon, in next 20, 25 years, minority will be the majority. Yet we have not kept the professional, you know, more and more Asians, Latino and Afro-Americans, Indian, you know, they are the majority. And on the other hand, you have only about 10, 12% of the doctor providing the care.
That's really good.
So I think it's very important that we keep up with that because they can relate better. They feel good. You know, when you go in your home, you feel better with talking to your family than somebody else which you don't know.
There's been a question of trust for various historic reasons where patients of color just come into a space and they do not feel comfortable. And it just should be said here that that also means then, because the trust is so deep, they don't necessarily feel comfortable with doctors of color either. They're like, what, cause what? I've never seen you. What's going on? You're part of this system. So we want to show this clip from the television series House. It's a black patient with high blood pressure who's suspicious of the prescription medicine that's developed specifically for African Americans. He first challenges actor Michael Phelps's character, who's black, Dr. Foreman, an African American doctor, and later House, who is white. Take a look.
Crackle, pop. Got some Rice Krispies in there.
Not bad, huh?
You were here yesterday. I see from the chart that Dr. Foreman prescribed medicine, not a miracle. Got to give this stuff one today.
I didn't feel that Oreo's prescription.
On the theory that you didn't trust him because he's black. Well, I'm going to prescribe the same medicine. See if you fill it this time.
I'm not buying into no racist drug, okay?
It's racist because it helps black people more than white people? Well, on behalf of my peeps, let me just say thanks for dying on principle for us.
Look, my heart's red, your heart's red. And it don't make no sense to give us different drugs.
You know, I have found a difference. Admittedly, it's a limited sample, but based on my experience of the last 90 seconds, all black people are morons. Sorry, African Americans.
I'll see another doctor.
Fine, fine. I'll give you the same medicine we give Republicans.
Okay, so that's a humorous take on it, but this is a very real situation that I know all of you have had to face at some point, to have your credentials questioned, and that's married with a trust factor of like, are you part of the system, or are you really here to help me? And that's a tough situation to be in. I'll go with you, Numa.
It is. I mean, and we cannot blame, you know, these populations, you know, a lot of the racial minority populations, African Americans. I mean, we have a history in our country that we need to accept. We need to deal with it, right? And if we don't put it out on the table and try to sort of hide it, you know, because it's been now 20, 30 years and things are different now, we need to come to grips with the fact that we did treat these populations immorally, I mean, unethically, right? So first of all, accepting that is the first step. The other thing is, every time you talk about a patient issue, you know, one of my mentors says, you know, if you talk about patient trust, you can also flip it and talk about, well, what is the provider or the system doing, right? So rather than saying, well, you know, it's just black patients just don't trust their physicians. Well, maybe you say, well, why don't we talk about what kind of curriculum do physicians have to relate with racial minorities, Because if we just leave it as, well, just racial minorities are just, they don't trust. Okay, well, I guess that's a problem we're never going to find a solution for, right? But if we actually look at what can we do to start to build that trust, then we can make some progress towards, bringing down some of those barriers that are there for very good reasons historically. Right?
And just let me mention, in case people are not, or ahistoric, one of the most famous, of course, is the Tuskegee experiment, in which doctors just watched 400 black men with syphilis and observed them to see, how the disease would impact and not treat them properly. They were told they were being treated, but they were not being treated. Coming closer to this time, there we have the Dalcon shield and some of the intrauterine devices that were first tested on black women and poor women. And then the father of gynecology is Dr. Marion Sims, and he did his work on enslaved black women without anesthesia. So, there's a history that is people are well within, they gain their trust honestly. Now, something, Dr. Ford, that you said happened to you during your training, I'm going to pick up on what Dr. Perez has said, is that you were challenged to, because you are in the rehabilitative space, to follow a patient in a wheelchair. And you were thinking that maybe the thing to do is to have physicians that are not culturally competent sort of immerse themselves in a situation similar to the one that you did in that way. And you had a different outlook just from your experience.
Yes. Definitely. And well, as a rehabilitation medicine resident, I'm very lucky. Actually, it was part of my program requirement during my residency to spend a day working from a wheelchair and living from a wheelchair. And sure, I try to be sensitive, think I'm pretty empathic, but I didn't really get what it is until I was somewhat trying to put myself in those shoes. And it was challenging. I had to go around the community in the wheelchair, and people looked at me differently, and I experienced some of it. I mean, it's not the same, but it was a little taste of some perspective. And then we had to spend a day with somebody required, who was living with a high tetraplegia, so a spinal cord injury, and was going to work and going through his day. I had never seen the details of what goes on in everyday life. So in medical school, spending time at the Adolescent Health Center in Harlem, it opens your eyes a little bit. And I think that taking care, the people we take care of, we've got to connect with every community, and I think it's just sort of about our whole society. We are a multi-ethnic society, and yet we're living in these silos, and if we can build some bridges, it would go a long way, toward breaking down this us versus them. Yes, we need a much more diverse workforce, and in the meantime, those of us who are not belonging to the group that we're serving, which is not going to happen most of the time, we have to kind of find that. And I think there's more cultural competency that needs to be done during elementary school all the way through to residency, as part of our training. And I don't think it was necessarily part of our structure in medical education formally. Here and there it was there, but it could be a much better kind of integrated educational, goal.
Okay, well, we have via Skype from California, Karen Jordan. Karen is a journalist who's working on The Story of the Doctor, a documentary about her family, which produced a trio of doctors, her father, her great-grandfather, and her great-great-grandfather. And their work as medical physicians dates back to the late 1800s and examines how they dealt with bias and discrimination in the different eras. Hi, Karen. Thanks for joining us.
Thank you for having me.
I wonder if you would just put into context, because one of the things that I'm edging toward now is that mentorship is really important. And you have 3 sets of doctors in your family, but as we've heard, you can't be what you can't see, and they didn't see any of it except for your father, who came after the other people. So how is it possible for them to have made it? And just share that with us about why it's important that we know this history.
Certainly. It's very important that people have mentors. My father, as you said, did have 2 mentors, although they were both deceased before he was born. But his great grandfather, Dr. Everett Ramsey, was the first black doctor in Houston, Texas. And he graduated from Meharry Medical College in 1880. And my father's grandfather, Dr. John Jordan, graduated from Meharry in 1896. And he became the first black doctor in Cowardly County, Georgia. So my father grew up actually in Coweta County, Georgia, in the house that his grandfather had built. And when his grandfather graduated from medical school, at that time, black doctors were not allowed to practice in white hospitals. So what he did was he built his own hospital for black patients right next to his house. And that hospital was still in existence when my father was born. So my father followed in both of their footsteps and graduated from Meharry Medical College, and then became the first black resident at Vanderbilt University Medical Center in the 60s, really in the height of the sit-ins. He started his residency program the day before the Civil Rights Act was actually signed.
What does it say now that we are looking at numbers, as was said earlier in the show, that haven't changed much, and they should have by now? I mean, some other things have changed in our society, so you would have presumed that these numbers would have.
Definitely. I think it's a very sad fact that those statistics have not changed. My father and many of his colleagues are saddened by those figures because my father actually devoted all of his career to teaching future black doctors. He taught at Meharry Medical College for more than 40 years. And he devoted his life, his career, to making sure there are opportunities for other black doctors. So those types of statistics are really sad in 2019.
And what would you say to people looking at the story of the doctor through your family and thinking about the field now, about how your story is emblematic of maybe what could change? Because they became doctors in some tough times.
They really did. I think that people have to not only look for mentors, but people have to find ways to create opportunities for themselves, because there are always going to be obstacles, whether those obstacles come in the form of racism or something else. They will always be there. So you have to make a decision, I think, as an individual, that if you want it badly enough, you're going to find a way to make it happen.
All right. Thank you so much, Karen.
Thank you.
Good luck on the project.
Thank you so much.
I just wanted to introduce that mentorship piece because I know you've mentioned it a lot, Dr. Perez, about you've referred to your mentors quite a bit. And, that seems to be the connectivity. You're nodding your head.
Absolutely. Mm-hmm. I have to say, I think that's one of the most important aspects of seeing those numbers change. When I look through the numbers and I reflected back to when I was in medical school and thinking about these numbers, the fact that I didn't necessarily have a lot of mentors, but was fortunate to find those mentors, one of the things that I think is now becoming more evident as I'm now faculty is that there's still a certain sort of lack of mentorship even at that level. And so when I look at sort of the programs and efforts that different pockets of universities or communities are doing, we're starting to focus more on the younger generation and trying to reach out earlier in the process. But that part of mentorship has got to involve mentoring our current faculty, making sure that they also find it value and importance, because they are who are going to be able to be the mentors to those high school students, elementary school students. And right now, I feel that as we talk about diversity and inclusion, having programs that are sort of centered around taking our faculty and teaching them how to be good mentors and how to be involved and how to walk across the street and meet each other. And so hopefully I think by focusing on those areas that the mentorship aspect will improve. I think it's absolutely important.
Well, you are mentor with capital M.
Yeah, well, I think it's very important what she's saying. One of the things is we have to educate, and mentorship should start early. We have to go in inner city and the high schools to start telling the kids what it's like to be a doctor or nurse or whatever healthcare. Then they have to do. And I'll give you an example. It was a girl I operated very early, 30 years ago, had a ventricle septal hole in the heart, and came from Cape Verdean girl. Nobody was educated in the neighborhood from Fall River. And I got a letter from a kid who was 10 years old saying what it takes to become a doctor. And I wrote a letter to him, what it takes to be a doctor. I had time those days, so I wrote a nice letter, and it was fine. I never heard it. Then 10 years later, he was working as an orderly in my operating room. And then he said, could I watch a heart operation? Of course, you come on in and watch. Those days, no HIPAA, so he came in and watched the operation. At the end of the operation, he said, you don't know me. I said, no, I don't know you. He took my letter out and showed me. He said, I'm going to Albany Medical School. and he became a doctor. So I think a mentorship and educating is the most important thing, you know. And the other thing is a socioeconomic situation.
Right.
Most of the, if you look at the medical students are coming from, where they're coming from, middle or higher class, look at their income, the family, 80,000 and more, not from 30,000 or 40,000, it's so expensive. So I think we need the help there, you know, more scholarship.
Well, that's a mentorship situation too, to talk to them about that.
Yeah, and a mentorship. Those are two, but we have to do mentorship early, not later when the college do. We have to educate them in the high school, elementary school. This is a good profession, and you serve the community and humanity.
Well, that's a good note to end on right now at this moment, but we're going to pick up and continue that conversation because that's key to seeing more faces like yours in hospitals and medical facilities around the country. So I thank you for joining me for the broadcast.
Thank you.
Thank you.
And that's the end of our broadcast and the end of our show. And thank you for watching and staying with us right now as we continue our conversation on Facebook Live and Twitter.